Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget that you can download this PDF of today's ECG down in the document linked below in the description. And don't forget to like this video and subscribe to the channel if you enjoy. So let's go ahead and get started. So the first thing I like to do is look at the force and just get an idea of what we have going on. If I look in rhythm, maybe in rhythm strip V5, I know I've got a narrow complex rhythm that appears to be very regular. And you see that regularity goes all the way until we've kind of got this early beat that looks a little different. So we'll kind of check that out later, but otherwise things seem to be normal. If I look at the rate, I can see if I do this QRS that lands on a solid line, I've got 300, 150, 100. This would be 75. So in between 75 and 100, maybe we'll call it 80 beats per minute, right? So we've got a rhythm at 80 beats per minute, and if I look, I see some P waves that are in front of my QRSs. I see some P waves. So let's evaluate what I think's going on, right? Let's evaluate the morphology of that P wave. P wave seems to be upright in lead 1, upright in AVF. That tells me that it's likely a sinus P wave coming from high in the right atrium going down to the left throughout the atria, which is what we expect. Next thing I look at is the next thing in the conduction system, which is my AV node. And my AV node is best represented by what? The PR interval. I can find that my PR interval, if I maybe look here in V3, I've got a PR interval that is, right here, PR is less than 200 milliseconds, right? It's actually about 160 milliseconds, right? So that's normal. We know normal is in between 120 to 200 milliseconds for my PR interval. But that doesn't tell me everything about the AV node, right? We don't just memorize PR interval. We memorize and understand that the PR interval tells me about the AV node function. And so we need to also scan through and look for any P waves that are buried in these T waves that might not be conducted, right? And so I kind of scan through and I look for any extra P waves. I don't see any, right? You kind of look through the entire rhythm. I don't see any, so I'd say everything is normal with my AV node. Next thing I have is my QRS complex. My QRS is narrow, right? If I look at the duration of my QRS, QRS is about, QRS we'll say maybe 100 milliseconds, right? Like maybe 2.5 small boxes, that's normal. My QRS is narrow and it is upright in lead 1, but it's negative in AVF. Tells me it's going away from AVF, but towards lead 1. So if I look at that, what does that mean? That means it's going kind of up into the left, right? So we have a little left deviation of our axis, and it's actually negative in lead 2, which tells me it's probably somewhere in this quadrant. So we've got left axis deviation, right? More than the negative 30 degrees that is represented by AVL. So it's somewhere up in this way. And so what could cause left axis deviation? Well, we could have left ventricular hypertrophy. I don't see that. I don't see massive R waves in my lateral leads. I don't see the amplitude of AVL to be greater than 11 millimeters. So no LVH to cause my left axis deviation in the setting of a narrow complex rhythm. So we'll see, maybe there's some other reasons why. Next thing I do is I'm going to evaluate my QT interval. My QT interval, what I could do is I could find an R to R, maybe here. If I look at the midpoint, my T wave should end by then, and I see that, so it's a normal QT interval. And now we're going to look for any pathological Q waves, which tells me if there's been a previous myocardial infarction in a certain region, and some ST wave changes that tell me if there's any active infarction going on. And so the first thing I noticed, and the thing that you probably have noticed this entire time, is we can come up here to the inferior leads that are leads 2, leads 3, leads AVF. And if you notice, here's my baseline here in lead 3 is a baseline, and there's my ST segment. AVF, here's my baseline, and here's my ST segment. Same thing in AVF, you've got a little bit of ST segment elevation, and we've also got these hyperacute T waves. Hyperacute T waves mean that the T wave is more of area under the curve versus less area under the curve, right? And so that's a hyperacute T wave as well with ST elevation in the inferior leads, leads 2, 3, and AVF. So we're worried about an inferior STEMI. Right, we've also got some evidence of these deep negative waves that could represent that this infarction has already kind of been progressing, right? So maybe there's already been some infarcted tissue within the inferior portion of the myocardium, and that might explain why, if my inferior portion of the myocardium, kind of down here, represented by leads 2, 3, and AVF, is starting to die, it's starting to infarct, well, my QRS, when it goes from my AV node down, it's going to head up and to the left. It's not going to be able to head that way. It's going to head that way. It's the only really area of viable myocardium right now. And so then you look, we've got elevation in the inferior leads. So then you want to look reciprocally in leads 1 and AVF for reciprocal changes, and look what we have. We've got reciprocal ST depression in my lateral leads, right? Lead AVL the most. So we've got reciprocal ST depression in my high lateral leads, which correlates to my inferior STEMI. And then the last thing I noticed is that in V2, I've got some ST depression as well. In V2, ST depression in lead 2 represents posterior involvement, right? So what happens here? We've got what we see as inferior ST elevations. We've got lateral ST depressions, and we've got V2 ST depressions. So this tells me that we've got a let me do it the other way. We have an infero-posterior MI. In what artery, commonly 80% of the time, is what's feeding the inferior portion and the posterior portion is the right coronary artery, which often gives off the posterior descending artery, right? So that would make sense that our posterior descending and right coronary artery are kind of occluded together when you just get a single occlusion of the RCA. And so the last thing we got to do, now that we've done that, is we need to figure out, what about this beat right here that we said is funky? Well, it's early. It's a premature beat. You can see that the QRS is a little bit wider than the normal QRS. It's got a different morphology to a degree. So I would call this maybe a premature ventricular contraction. Well, why do I say that? Well, if I look in front of it, I don't see any evidence of atrial activity that could be causing this premature beat, and so that's a premature ventricular contraction, or a PVC. Alrighty, so let's put this all together, and what do we have? We have a sinus rhythm at a rate of 80 beats per minute. We have left axis deviation that is best explained by inferior ST segment elevation in my inferior leads 2, 3, and AVF, with some posterior extension as evidenced by depression in V2, and reciprocal changes in my high lateral leads 1, and AVL. So this is all very concerning for an infraposterior myocardial infarction. And let's not forget that we have a single premature ventricular contraction. So I hope this helps kind of understand a little bit of the coronary artery anatomy. And if you have any questions, feel free to throw them down in the comments below. I love talking about anatomy and physiology, and for ECGs, right, electrophysiology. So I hope this helps, and thank you so much for watching and supporting the channel. Have a great day. See you on the next ECG video.